Week 3. So one of the things that you guys have to remember is that if it's not in black and white, it didn't happen. Also, because of the nature of our profession, we can be summoned or subpoenaed to a court of law. So chapter 3 is really important, okay? We're talking about medical legal aspects of our world, all right? So let's jump into what we've got going on. We're going to be covering law, documentation, and professional ethics. But before that, when you want to succeed, as bad as you want to breathe, then you will be successful. Our role is extremely important. Success isn't just about learning skills. It's about having a deep drive to constantly improve. I want you to think of it like this. Just like you need air to survive, you need a passion for what you do. When you go in and you start approaching your studies and your practices with that same urgency, giving anything less than your best isn't an option. I want you to think about the determination that's going to keep pushing you to be better every day. And that's what leads to true success. So keep that fire burning and you will go far, not only for yourselves, but for the patients whose lives you impact. Because remember, you are that patient's advocate. All right. Now, for our learning objectives, we're going to be talking about law, but how it relates to us in the operating room. We're going to look at risk management. We have to talk about the difference between a licensure, certification, and registration. We are going to discuss abuse and violence in the perioperative environment, unfortunately. Sentinel events. We have to know these because, again, you can be subpoenaed back for whatever happens in that operating room. If your name is on any document and a patient has an issue with something that happened, let's say you were a part of a team that years later they find out that a entire malleable instrument was left. I know exactly how that happened. You're going to know too once you get into the field, and then you're going to be like, aha, I see how that happened. Even with doing all of the checks and balances, remember to err is human. We also have to go over common areas of negligence, especially in our practice. This is not a very long chapter, but an extremely important one. Okay. Now, laws are rules made by the government just to guide certain behaviors. In surgery, regulations and laws ensure that we follow safety protocol, we keep things sterile, and we really just communicate because communication is key. All of these rules come in and they help us define the duties and ensure that, again, we are adhering to patient safety. Now, we have to understand the laws of surgical tax because we're going to be held accountable. And we also want to provide the best care. We are guided by both administrative and state laws that really just shape everything that we are responsible for in the operating room. Now, they also guide our behavior, especially in the healthcare industry. And breaking them can lead to serious consequences that I don't want any of you to be involved in. Some laws, believe it or not, are widely known, while others may not be as familiar. We have to understand these laws because they impact how we're going to work with our patients. The government ensures that these laws are followed, right? But whether we agree or not with the law, violating it has consequences. State law refers to laws that are created by the state legislature. Okay. We look a lot at risk management. We are trying to ensure that we are preventing no harm to patients, to our staff, and any visitor. But there's certain things that we focus on. We focus on education, we focus on promoting safety, we ensure that there is compliance with safety protocols, providing follow up. We are always being trained on the nuance of what's going on in the operating room. There are reporting policies and collaborating with risk managers. All of these efforts help create a safer, healthier environment. All right, so now let's break down certification, accreditation, licensure, and regulations. Certification confirms that an individual has met the required standards of knowledge or performance. Licensure is a legal requirement set by the state to regulate professionals and ensure that they meet specific standards. So, we talk about registration as well, where again, we're trying to maintain standards. Once we are nationally certified, we're kind of a little bit different because as a national certified surgical technologist, you're able to work in all states in the United States. All states in the United States. But let's say you're a nurse and you get your license in California. Well, some states will make you re-register in another state. So let's say that same nurse moves to New York. Well, even though they're a nurse, they may still have to take the state license exam so that now they have their license in California as well as New York. Okay. But we are nationally certified. We look at abuse and disruptive behavior. Okay. Again, you are your own advocate as well. All right. But when we look at per the book, we're talking about, for example, bullying, where there's repeated aggressive behavior towards you or a coworker, like yelling or just spreading rumors. When we talk about hazing, this is a form of harassment, okay? Initiation rituals that can be humiliating or harmful, and they're often aimed, unfortunately, at new employees. Sexual harassment, unwanted advances, or comments of a sexual nature that create just a hostile working environment. Disruptive behavior, actions that interfere with the work, such as constantly arguing or just being overly loud. But how does this affect the workplace? I'm going to turn that over to you all. How do those type of workplace abuse affect how you're going in and out of the workplace every day? And you guys can type in what you think. Keep in mind, there are no wrong answers.
Can you repeat the question, please? I'm sorry, it cut off.
Oh, no worries. So, when you're looking at the types of workplace abuse, how can this affect your workplace going in and out of the operating room? If you're dealing with any of this, how is this going to make an individual feel? I've got uncomfortable, makes you uncomfortable in the work environment, makes you less willing to want to be there, creates a stressful, toxic environment. It can cause you not to be in the right headspace, makes you feel small, less confident in your qualities, doesn't make you want to be there, low self esteem, you're distracted, unable to perform. Yes, these are excellent. And at the end of the day, who is the most vulnerable there? Who is this going to affect if you're not in the right mindset? If you don't want to be there, if you don't have the confidence, exactly, the patient. It, morale is decreased, increased stress. This is already a stressful job, right? Like you're inside of a patient's body, right? Trying to fix them, heal them, sometimes bring them back from the brinks of not being here. And now you're adding additional stress, which can lead to burnout. You're not going to be as productive. I love the confidence because your confidence does decrease. So, what do? So, we promote a respectful culture. We try to encourage kindness and support among coworkers. There's going to be lots of training, workshops, recognizing and really preventing workplace abuse. And a lot of facilities, they have clear policies where everyone knows the rules against abuse and, more importantly, how to report it. There's a safe space for employees to kind of discuss experience and really just seek out. But the very most important thing that I can tell you is to be your own advocate. Just like you're the patient's advocate, advocate for yourselves. It is extremely important in our field. All right. So I feel it is so important to see the other side of Sentinel events. And what do I mean? Well, on our side, we know when it happens, we'll get the, oh no, this is an outcome, but we never see it from the patient's point of view or how it affects patients per se. And so I found this NBC News YouTube that I was like, it's not that long. It's about 2 minutes. But after we watch it, I want to come back and get your thoughts. So let's take a look.
Our lives changed forever at that moment.
Losing her child in 2002 led Lenore Alexander to change her life and to become a patient advocate. Her 11-year-old daughter, Leah, was admitted to a Los Angeles hospital for elective surgery to repair a chest deformity. Following surgery, she says Leah's condition spiraled.
And I kept telling them she was in a lot of pain.
Lenore says she fell asleep next to Leah's hospital bed. When she woke up,
I looked at her. I knew that that wasn't Leah, that was a body. And I screamed.
What was the cause of death?
They put cause of death unknown.
But Lenore blames what she says were mistakes made in the hospital. And an autopsy report shows an epidural catheter was found in tissue in Leah's chest wall, not in epidural space. The hospital told NBC News it was unable to discuss the case due to privacy laws. Patient safety is an issue highlighted in a new study examining patient data from 2018 that found nearly 25% of patients hospitalized experience an adverse event. Nearly a third of those events considered serious and more than a fifth of them preventable, many due to error involving things like medication or surgery. And the study's authors worry with the pandemic.
There are reasons to think that it could even be worse because we have so many issues today.
To help keep yourself safe in the hospital, experts say ask questions, know what medication you should be taking, and bring a family member or friend.
It's so easy to teach people basic patient safety, and nobody really thinks they need it until they need it.
Erin McLaughlin, NBC News, Agora Hills, California.
Thanks for watching our YouTube channel. Follow today's top stories and breaking news by downloading the NBC News app.
All right. What are your thoughts? What do you think after watching it? How can that happen? And those are great questions, right? Unfortunately, a lot of times to err is human. And that is the exact right question without being in that particular case at that particular time. Unless we have the report, we're not going to exactly know the ins and outs. Okay. But I showed you because I wanted you to kind of almost put yourself in the family shoes. One of the things that we do in the operating room is the questions that you're asking, which is correct, amazing. That's how we think. But it's also good to take ourselves out of our analytical setting where we're like trying to figure out how it happened, what we can do to fix it. And that's why I'm not elaborating, because I really want to focus on the response of the family members. The patient's mother response was accurate. Patient safety, very important. Thank you. That's where we're going to. Family members need to be a voice for their loved ones at all times for situations like this. This is also one of those times where if you were involved in the situation, it's kind of tricky, right? Because there's going to be reports, there's going to be investigations. If your name's on that, you're going to be pulled in. And that's why this particular chapter is so important. Sorry, but we still have to kind of have empathy as we're doing our job so that maybe sometimes we step in. There are going to be many a times where you're going to be in a case and you're the one that has helped prevent a Sentinel event or a near miss event. Being that patient advocate is more than just making sure we're passing the right instruments or making sure that we've done the 5 rights when it comes to medication. It's looking past that. You're watching who comes into your room. It's going to happen. You're going to be watching who comes into your room. You're going to be watching who's coming around the patient. You're going to be double checking what's on your field, what you have, your medications, everything. But to err is human. We get out of how it happened to what can we do to prevent any type of situation where now a mother's trying to find out, where do I go from here? Does that make sense? Okay, awesome. All right. Common areas of negligence. So this is going to kind of tie into the video where we're asking, well, how could this happen? We're going to talk about preventing common areas, okay? We're looking at unintended retained foreign objects. We have to make sure that all of our instruments and sponges are accounted for before, during, and after a procedure, just to avoid leaving foreign objects inside of the patient. When you're doing a big belly case, okay, an open abdominal surgery, as you're closing the layers of the tissue or reapproximating skin edges, muscle edges, there's a certain time where we use an instrument called a malleable, and it's a long metal instrument that is very flexible. And unfortunately, there have been times where patients have been having problems where they couldn't cough, they couldn't sit up, and years later they go and get an x-ray and I'm talking about, it's about this long, it's about, say, yay thick, was left into the body. And as a tech, I'm like, I can see how it happens. Not that it should, but I can see how it happens. When you're doing the count, as soon as you give that surgeon the malleable, and usually give them an OPDS looped suture, you guys will learn this in module 3 and moving forward, so don't stress, just go with me. It's a bigger, thick suture. As you're closing that, they put the malleable, the instrument, to protect the soft tissue, the intestines and the organs underneath as they're closing it, so that you're not stitching the intestines into the muscle wall. Does that make sense so far? You guys with me? Okay. So they have it in and they're suturing. Okay. And they pull it out. You're counting at the same time and it goes back in to the other side. And then they meet in the middle and tie it off. I can easily see, not justifying it, how that could get left in, because you're counting as you're suturing, as they're suturing, and you always have to mentally remind yourself, I need that back. I need that back. Now, if it's a fast surgeon and they're just suturing, and you've already counted the malleable, because you usually do an instrument count before the case starts. If you switch teams, you'll do an instrument count, and then you do a big instrument count before you close. So you get that big instrument count out of the way. They're still closing, but you get the instrument count out of the way. Then you move to your small count. You still have to mentally remember that malleable needs to come back. Now, granted, you're responsible, but every member of that team is also responsible. Okay. Burns. We have heat sources in the operating room. Cautery devices. These are devices where we use like a bovie and it has kind of like a electrical cutting thing where patient can be burned, right? During a procedure, not from the bovie, but from other things. All right. Falls. We have to make sure that the patient is on the operating room table correctly. We look at incorrect patient positioning, which is another big thing. Okay. We also have what you see right here. We mark our patients now. Well, we always have, but we are a lot more adamant about how they're being marked. Because let's say a patient comes in for a left knee amputation and they leave with a right knee amputation. That's a problem because then their bad leg is still there, but now their good leg is gone too. Specimens, that's a big one. You do not want to mislabel a specimen. This could be the determination of whether a patient has been diagnosed with a cancer or something else. You see medication administration, that's going to be hospital-wide, but we're still checking when we're handing medications to surgeons. I had a student, and I'll get more detail at Module 3, that I want to say around 2008 had to be removed from clinicals because they almost gave the patient the wrong medication that could have killed them. Okay, so it is no joke when we talk about these different things. All right. Abandonment. We have to remain present and engaged in our role during the entire procedure and ensure that we are following proper protocols. So if we have to leave the room, you guys should be asking, but what happens if I need a break? Well, you will let your circulator know, and then you will get a scrub to come in and scrub you out. If you have a really awesome circulator that can also scrub, sometimes they'll scrub you out so you can get a break and come back as well. And then communication. Clear communication with the surgical team is important. Let's say me and Diana are communicating and I'm like, oh my goodness, I just lost a laparotomy sponge. Okay. She's my circulator. I'm scrubbed in. She's going to be like, okay, hold on. We're going to count starting from the sterile fields. The sterile field is where we cut. So whenever we talk about the sterile field, that is cranium, shoulder, abdomen. That is where we're actually cutting on the patient or going into the patient. Okay. Then we go to our Mayo stand and then our back table. We're going to explain all of that. But communication is the key. We also don't want to have loss or damage to the patient's property. And we have to know our scope of practice so that we avoid delegating tasks that are outside of our responsibilities or level of competency, which is really, really important. We're halfway through the chapter. The next part, we look at documentation. Again, if it's not in black and white, it's not done. We're going to look at adverse events, perioperative environments. We're going to get into examples of now negligence that occur in the perioperative environment. We have to describe what a legal document even is, look at a law versus a standard, and reasons why all of that bad behavior exists in our environment in the first place. And then, of course, look at advanced directives. So, documentation. Okay, well, clear communication, continuity of care, and legal compliance is a lot of the reasons why we document in the first place. Joint Commission sets standards for documentation just to make sure that things are accurate and complete patient record. Remember, this is a legal document. When we look at HIPAA compliance, It protects patients' privacy and confidentiality, and documentation must adhere to all of those regulations. Proper documentation not only meets these standards, but also improves patient safety and care quality. We, as healthcare professionals, must stay up to date on all of these requirements just to ensure compliance and protect the patient's right. Now, how does accurate documentation in the surgical setting contribute to patient safety and legal protection for us? What do you guys think? I see precision. I like it. Elaborate a little bit more. Okay. Being precise is a critical detail for complicated situations. A lot of times, that's what we're dealing with, complicated situations. I love that answer. Think of it this way. We're all one team, okay? All 21 of us. We're going to just be one tech right now. So just go with this. Go with me for a second. We are scheduled for an emergency craniotomy where we're going to drill into the cranium because there's a bleeder. And the surgeon wants, let's say, a diamond burr. Okay. We send our circulator out, but we forget to mention that they want a diamond burr and they come in with something different. And we go ahead and we start doing it. And because of that instrument, I'm being extreme because this wouldn't happen, but just go with me. Because of that, we go into the cranium, but for some reason the drill doesn't go all the way through. And so we are having jagged edges and things are just crazy. And then as we take off the skull, which we do, we notice that something's not right. Okay. What would happen if we did, right? You're not meeting the patient's needs or wants. You're like reading my mind. Communication is the key. So that's the first one. We're having a clear record. We're looking at communication. Okay. Remember that we want to be compliant because there may be legal questions that come. Okay. We want to verify that the correct procedure was followed. The doctor wanted a diamond burr. We get the surgeon a diamond burr. Okay. We want to protect both the patient and the whole team for any legality. So great. I want you guys to think outside the box because it can happen. Now, common documentation. If you already work in healthcare, a lot of this is kind of familiar. All right. Patient record, medical record. It's going to have the patient's health, history, and treatment details. Informed consent is proof that the patient understands and agrees the procedure. True story. I'm at the surgery center and we're going in and we're doing a shoulder arthroscopy, which is just a shoulder scope. We're going in and we're seeing what's wrong. We notice that the patient has a labral tear, which is a tear in one of the tendons in the shoulders. Okay. Do you think now the patient was only consented for a shoulder arthroscopy? Do you think we can go in and fix the labral tear even though we see it? And the patient is intubated. They are unconscious. What do you guys think? And then I'll tell you what we did. Do you think that we have permission to just go in? Oh, we see the tear, open up the equipment and let's go. What do you guys think? That is correct. Patient didn't consent. So what we ended up doing is we finished up the shoulder arthroscopy. The surgeon detailed anything or wrote down and dictated all of the findings. And then once the patient was awakened, they told the patient and they rescheduled. What we normally do, and this was at the surgery center, which is different, but a lot of times what we'll do is we'll consent if we see something, then it's already consented to be fixed. So like, let's say on the x-ray, it looks like there's a labral tear or a rotator cuff tear, then we will actually consent to a arthroscopy and labral or rotator cuff. So it's also going to be on facility practices. That particular practice is we're going to go in, we're going to see, and we're going to inform the patient everything that we do notice. And then if need be, we'll reschedule them for another surgery. Okay. Now that's informed consent. When we look at the intraoperative record, that's just everything that we're doing while we're in surgery. Anesthesia has their record. We are charging the patient. So the circulator, while they're helping us, they're still documenting everything that the patient will be charged with. Other things that the chapter brings up are birth and death certificates were just official records of a patient's birth or death. And we are very, very meticulous as to specimens and pathology. And these are just documents of any tissue taken during surgery for testing. And depending on the facility, sometimes anything that's removed from the patient's body has to go to pathology. And I say that because when at the surgery, not the surgery center, but at the children's hospital, we were removing coins out of little ones that would swallow coins. And even though we knew it was a coin, we still sent it to pathology because that was the facility's policy. Okay. Again, breaking down that informed consent a little bit more. You guys hit the nail on the head. We didn't have consent. Why? Because this is a legal document signed before surgery, ensuring that the patient understands and actually agrees to the procedure. So had we gone in, even though we knew what needed to be fixed and did it without the patient consent, that is a huge legal problem. Why? Because the consent is telling us what surgery in both medical and simple terms. We have to talk about the risks that could have happened, both good and bad. The surgeon also has to offer possible options besides surgery. So even though we know that that's labral tear, we could fix it, the patient may be like, I want to try this instead first. And by the patient signing it, it shows that the patient agrees to go forward with the surgery that was presented to them. Now, we look at Sentinel Events and we try to get out of the they did it, no, they did it, no, blame game. When we talk about a Sentinel event, it is an event that causes injury, harm, or death, or one in which there was a near miss of any of these events. Question to you: how soon should the event be reported? What do you guys think? Right away. Yes, correct. Right away, immediately. If you see a question like this in the near future, just know that it is immediately, ASAP, right away. Okay. Just saying, if you see a question. And why do we do these reports? Now, the incident report helps to identify areas of improvement. Again, steering away from the blame game and to ensure that safety protocols are upheld in the surgical environment. Why? Because to err is human. Okay. Even though we're not trying to make mistakes, mistakes do happen. And instead of trying to cover it up because you're the patient's advocate, you want, thank you, documentation to really protect yourself. Now, negligence, acts resulting in harm. Harm can be physical, like an injury, or psychological, like stress. We have to avoid causing harm to really just uphold ethical and legal standards. When we look at negligence tort, I have seen questions on the CST exam and I have seen questions on your midterm. Not saying you'll get them, but I have seen it pop around. Negligence tort, when someone fails to act as a reasonable person would, that leads to harm. Here's an example. Forgetting to count a sponge or leaving one inside the patient could be considered negligence tort. Intentional tort, when someone deliberately causes harm, like they know that it's wrong, like administering the wrong medication on purpose, harming the patient. I don't know if you guys saw that news about that nurse that was purposely injuring infants. I don't know if you guys saw that. And I was like, oh my gosh, right? And I was like, huh, that's really happening. That's an intentional tort. Okay. A lot of times to um get these terms to stick, think about real life things that are happening. So when I think of intentional tort, that nurse comes straight to my head. I'm like, that was intentional. That's intentional tort versus negligence tort is it happened because of something they failed to do, not necessarily they did it on purpose. Does that make sense before we get into medical malpractice? Okay. Now, medical malpractice, let's say you have a healthcare professional and they're failing to meet standards or just lack skills causing harm. A surgeon's performing surgery without proper training. They're doing some huge cochlear surgery, like an ear, and their training was watching it on YouTube. And then all of a sudden, there's complications. That's a huge problem. Okay. We get into HIPAA, privacy. It includes, but it's not limited to what you see on the screen. Okay. Check with your facilities because they're going to have a lot of information where it's specific to that particular facility. But these are, it's not limited, but this is going to be some of that privacy stuff that we're trying to keep private. Okay. We also have different guidelines. So Joint Commission has a list of abbreviations. Every document must include the patient's unique identifier. The date must be accurate. You correct errors by marking a line, which is a little bit different because we have computers, so it's a little bit easier. Keep in mind, though, in the operating room, we are still hybrid in a lot of places, meaning we may have half of the record paper form and then the other is going to be electronic because we do have computers in the operating room. You want to make sure you use correct language and spelling. And this is huge with every like job. Always log off. Don't share passwords, and documentation must include a signature. That's all going to happen as you're in there. They have it where when you're audited, they know exactly what terminal, they know based on your ID and all that. Okay. Now, hospitals and other healthcare facilities are accredited by joint commissions. This is just standard policies that require to maintain accreditation. So once you guys get to your new facilities, because we're going to talk like it's already happened, you guys are going through the motions, you're already going to be STs. Once you get to your first hospital, surgery center, or wherever you start working, you're going to have some type of training. It's going to be required for all employees. You're also going to have to know hospital policies because if a policy has been violated, it may result in disciplinary action, and we don't want that. And each facility has operating room procedures manual that describes protocols for specific practices. For example, let's say you're at a hospital that's primarily OBGYN. That's going to be a little bit different. It's going to have a lot of the same, but a little bit different than a facility that primarily works with neuro. Okay, there's just going to be some things that they do that maybe they don't. We have professional standards and practices like American Academy of Surgeons. Of course, for us, it's the AST, Association of Surgical Technologists. We go in more detail in Module 3. There is AORN, Association of Perioperative Registered Nurses. One of the things that we do in the operating room is we go off of evidence-based practices. These are going to be based on decisions, up-to-date research, and facts. Okay, for example, if research shows that using a specific type of disinfectant reduces infections, we should follow that research and use a disinfection in the operating room. Luckily, it's not something that you as an individual ST would have to figure out. A group, a team is already going to have that done. And then next thing you know, they're just implementing it or telling us to implement it in our areas. Okay. Another thing the chapter talks about, code of conduct. Standards, okay? Written rules for us to follow. Honesty, professionalism, compassion, integrity. Now, there are causes of disruptive behavior in the operating room, and I'm going to be full transparent with y'all. I don't want y'all walking in there and just thinking, oh, it's all, clouds and flowers, because we are human. There is a hierarchy. The operating room often has a strict chain of command where surgeons or senior staff perceive to hold more authority because, they're the ones cutting and etc. This may make you as a new ST hesitant to speak up, especially when it's necessary. But I'm telling you to find your voice. You are that patient's advocate. There's strict leadership in some areas where some leaders will use controlling approach or create stress. And then there's fear and tension, potentially leading to conflicts or aggressive behavior. Again, find your voice. You are the patient's advocate. You are your own advocate. I want you to think about this. Let's say, because remember, you allow people or you show people how to treat you, believe it or not. The very first time someone is rude and you kind of brush it off, even subconsciously, they may think, I can do it again. And then next thing you know, it's a year in, and now you're finding yourself miserable, and now you're scared or even anxious to use that voice. So find your voice, make sure you're professional, and let them know. Okay. Negative behaviors like yelling or bullying may become normal if you allow it, if you don't address leading to a very toxic environment. And if you don't think it happens, it does. I think first month at the surgery center, I was with the surgeon at the time. I didn't know he was the owner, and these guys came a little nervous. He was the actual owner of the facility. And I was doing a case with him the whole day. And the lead tech was like, oh, he does it just like the Navy, blah, blah, blah. We were doing like shorter cases. And I was like, oh, cool, got it. We're doing the case. And the only thing he does like the Navy it was a shoulder. That was about it. Everything else was different. So I'm sitting here going, did he set me up? But I'm going with it. Now, my first name is Teresa. My mom's name is Terry. We're in the case and he's like, Terry. Now, I froze and I was like, no, he didn't just call me. And I'm looking around like, is my mama in the room? Like, this is going through my head. I didn't say it. And I stopped. I looked at him and I just stopped. Now, there's a lot of different ways. We're doing a shorter case. It was an emergency. There's a lot of different ways where you can kind of stand your ground without being aggressive or rude. And mind you, granted, I've been in tech for a while. So it was like, this is what we're doing right now. And I wasn't rude. I wasn't disrespectful. I just stopped. And I was like, right. And I'm like, yeah, my name's Teresa, right? Remember, this is the first time I'm really meeting him. Again, didn't know that he was the owner. Doesn't matter. After that, I was still making mental notes because I was with him the whole day. And this was our first case. The next 5 cases, he didn't even have to say anything. We were moving. It was like a nice oil machine. However, I showed him how I would like to be treating and vice versa. And after that experience, he would request for me to be in his room and I'd be like, oh my goodness. But it was because I wasn't disrespectful, but at the same time, I kind of was like, hey, this is the first time I work with you, the only person in the room that was really nervous was his PA, but it just goes to show you're going to learn, you're going to be able to find your voice because one, you want the patient to be taken care of. Does that make sense? Okay. And once you guys get in the lab, there's other ways you can learn too. Now, there are advanced healthcare directives that we have to talk about. The DNR. You do have questions on your exercises about a lot of these terms. DNR, a legal order stating the patient doesn't want CPR or life-saving measures if their heart stops. We in the operating room, we do honor this, okay? Organ donation. Patients may choose to donate organs after death. We're not finding patients off the street that are alive and taking their organs out of them. We may help with organ recovery procedures. These are very humbling cases, in my opinion. Harvesting, for me at least, is a very humbling experience because one life is taken to give life to others. That's how I always do it when I'm in those particular cases, like my mindset. Some patients decline blood transfusions or tissue products for personal or religious reasons. Again, we have to respect this and use alternatives during surgery. We're going to talk a little bit more about that later, but just know we may be in a situation where that is reality. And we look at medical power of attorney, a legal document allowing someone to make medical decisions for the patient if they can. We as the team have to follow the decisions of their representative. Now, these directives ensure patients' rights and wishes are respected during their care. So it's not very long, but what questions do you have for me?
It was all very clear.
Awesome. I
I
do
do
have
have
a
a question.
few.
I'm
Go
sorry.
ahead. I hear somebody.
Sorry if you hear my children. So about the no blood, because I know Jehovah Witnesses, they usually decline to receive blood.
Mhm.
So in those cases, like if they're bleeding out, do they have to sign
Against
the
medical,
DNR?
yes, they
Okay.
sure do.
Okay.
In those cases, and you've seen shows, because I'm gonna actually show you guys some shows where that actually happens, where like the patient's bleeding out, but for whatever reason they're declining medical help. They have to sign that they are refusing medical care. Because at the end of the day, for us, it's do no harm, right? And watching a patient pretty much die is kind of like doing no harm, but we turn it over, and legally, if that patient has signed it, witnessed it after we've given them all of the information, then it's hard because we have to sit back. Um, Oftentimes, though, not often, sometimes they do have a change of heart, or the family member that's in charge may have a change of heart. But that is a good question because it can and sometimes it does happen. Has there been a case where an ST did not want to do a case? I love this question. I talk about it in module 3, but yes, I've had at the children's hospital, we had a couple of techs that were assigned a case where, and for HIPAA, I'm not going to go into detail, but there was a case involving a minor that they chose not to for ethical reasons. And the case ended up getting canceled, but there was no um retaliation or anything to the tax. It was their personal belief, like they did not feel comfortable for their own ethical moral reasons to be a part of that case. So yes, you do have the right, and like I said, we do go into more detail in module 3 where I let you know, hey, this is what could happen, and you have the right to say no based on A, B, C, D, and E. And no one's going to look at you and be like, oh my gosh, I can't believe you did it. Because a lot of times, like, I wasn't even in the lineup, but I even felt like, whew, that's not a case I'm wanting to do. Great questions. Anything else before I get into the polls? All right, now I'm going to go ahead and launch it, y'all. For those of you who are watching the playback, I'm going to put these same poll questions in the archive. That's going to be like our little section, okay? So that you will get to see the same questions that everyone is seeing here this evening. There are 10 questions, and what I did is grab the 2 highly picked of the 2 or of the 4, so that once you see that question on a test, it'll help you to kind of be like, okay, I know the rest of these are outliers. Now, which 2 do I choose based on what I know? This is another kind of muscle memory exercise to help as you guys take these questions. Okay. So I'm going to give you guys a couple minutes. Probably after 3 minutes, I'm going to come back and then we're going to wrap everything up. Again, for those of you who are watching, you are going to have the same opportunity, except yours is going to be wrapped up in the archives, and then you can use that as a resource as well. Okay. So about 3 minutes, I'll be back and then we will wrap it all up. No worries. I see that it went away on a couple individuals. Okay, I'm gonna end it and I'm gonna share the results with everybody that is here. So about 52%. Are you able to see your scores? Or are you at least able to see the correct answers? Can someone let me know? No? Okay. So I couldn't see mine. Okay, so what I'm gonna do is I have this already broken down with rationale as to why the answers are what they are, and all of that will be in the archive. So for those of you who have not had the opportunity to see the poll questions yet, you're going to see a little bit more detailed. For those of you who are here that aren't able to see the correct answers with explanations, you'll see all that as well. I want y'all to just use this as an additional resource. My goal is to get that up this evening with the archive, okay? So you'll get all of that in that little archive section. Does that work for everybody? Okay, perfect. All right, so what did we cover? Well, we looked at, and I don't know why my ending is still backwards. So what we're going to do is we are going to just go to this one. There we go. We went over a lot of medical terminology as it relates to what we are going to be dealing with, from learning what Sentinel events are to understanding that if it's not in black and white, it's not done. We also know that we have to have empathy for our patients. We see how it affects the other side versus what we think about when we're in the operating room. How did it happen? What can we do to improve it? Let's not point the finger. Are we trained properly? Now we have the other side where we're looking at how the patient is dealing. Now there's a hole, there's a gap there. Okay. Our quote of the day, quote of the week: when you want to succeed as bad as you want to breathe, then you will truly be successful. For those of you that are watching the archive, 3 questions. Question number 1: how can you, as a surgical tech, use your voice and be a patient advocate? Number 2: what do you do when you see an event happening and the person that is doing this said event is your surgeon? Number 3: what do you do if you are the victim of bullying in the operating room? I can't believe we're already at week 3. In 2 weeks, we have our midterm exam. But I do not want you guys to stress out. You are going to get a review guide, study guide next week. You're going to get the highly missed questions from week 2 this evening, and then be on the lookout for your poll questions. What questions do you guys have for me? If there are no questions, thank you guys again for being here this evening. And I look forward to seeing everyone who can attend Thursday's live session of Micro. Good night, everybody.
Thank you, Nick.
Thank you.